start with the first speaker session of the day, Dr. Karin Rosén, who is on the board of directors of Diamyd Medical, Ginger Vieira, diabetes content marketing specialist, and Dr. Emily K. Sims, associate professor of pediatrics at Indiana School of Medicine.
Okay, very good. We'll take it off. So I'm Karin Rosén, and I'm a physician, PhD by training, of Swedish origins, and I'm in the Bay Area, located here since about 25 years. You can see the beautiful Golden Gate Bridge here in the back. So I'm going to take it up a level. And first of all, I just want to thank the organizer for inviting me. And as you heard, I'm on the board of Diamyd Medical, so I want to give that disclosure. So when we talk about diabetes, I also want to speak about women's health and how diabetes fits into this. And so even if we know that women, represent about half of the global population, remember that 80% of healthcare decisions or purchasing decisions are primarily made by women. And I want you to remember that number when we come to later points in my presentation. And what I will take you through are pretty much what are the gaps, also how diabetes fits into this, both from a research and funding perspective, but also the 5 pillars, some of 5 pillars of how we are actually going to address this gap. And finally, also that this is a huge financial opportunity, if you want, not only to close the gap from a health perspective, but also for investments into disease areas that are totally underfunded, as you just heard from Viveka. So I mentioned that 80% of decisions are made by women. Now, what we still have to ask ourselves, why is it so that women live 25% or more of their lives in poor health compared to men? So there is a report that's been put together by McKinsey Institute, and if we look at a third of the health issues that really has a huge impact on women's health, we're talking about 5 of these are conditions that really affect your lifespan. That means how long you live. And there's no doubt that ischemic heart disease or cardiovascular disease is still the biggest killer. About 500,000 people just in the United States, or women, die annually because of cardiovascular disease. And this is really important because diabetes is there's a high risk of diabetes patients developing cardiovascular disease. You also have cervical cancer. This could actually be avoided by some form of vaccine, which is still not being provided to hundreds of thousands of women are suffering from this cancer annually because we're not funding sufficient research or treatments into this disease. Breast cancer is another one, of course, that everybody knows about. This is also by far the most sort of common cancer for women. Then we also have hypertensive disorders, women that have, are childbearing. This is a huge problem, again, that is not, well known or researched into. And then postpartum hemorrhage, which is actually the biggest maternal killer in the world that, again, is not well known. On the right-hand side of this slide, you can see other, conditions that really affect women's health: menopause, PMS, migraine, endometriosis. All these diseases are, again, there's a huge prevalence among women. Still, there's very little research that's being done, and there's also very little funding, VC funding, going into these diseases that are actually affecting so many women around the world. So I mentioned that cardiovascular is still the biggest killer, and I want to bring out type 1 diabetes here because we have insulin since about 100 years, and it's a great treatment, of course, and there are other ways to help patients with type 1 diabetes. What I want to say, though, is that there's a huge unmet medical need here, and we really need to make sure that we develop drugs to preserve, the body's own function, because, as you can see here on this slide, women with type 1 diabetes, this is from a registry in Europe, have 7.7 higher risk times, developing cardiovascular disease. And what I mean by that, that's stroke, that's more myocardial infarct, that's a heart attack, or cardiovascular death. So these women are definitely in need of a treatment, and that you can start much earlier to prevent these terrible outcomes. So again, this is high level, and I can't go into this because I have just a few minutes to present here this morning, but I'd love to discuss this more with you. If we look at this, there are 5 major gaps that we really need to think about. And it is to collect data on women, to really understand what happens when we're developing drugs for women. How does this actually affect women in this patient population, not just the men, especially if men are the largest percent in a clinical trial. I don't know if you're aware, but it was not until 1993 that actually here in the US that the Congress passed a law to also include females in clinical trials. It's hard to believe that before that there were no such rules. And still today, we know that for a lot of medical indications, the majority of patients in these clinical trials have been males, and also males that potentially are older, or they are militaries. So you can imagine comparing a 240, that means about 120 kilo male patient, to a Asian woman that weighs maybe 60 kilos or less, 110 pounds, and with a potential different genetic makeup. You can't necessarily extrapolate the results from these type of patients and say, yes, it's safe, or it actually works similarly in this type of patient if you haven't studied them. I also think it's important here to build out guidelines to really make sure that they are evidence-based. So what data do we have for women then, and how do we share that with the patients that we're treating and that we're seeing in the clinic? And then education, of course, education. I mentioned the 80% in the beginning, and that's why I think this is so important, that if women are really making the decisions in households about healthcare, about how to treat their kids or even their loved ones, it's really important that we educate women correctly, and also about women's health, of course, because we also saw that a lot of more women are living in poor health compared to men. Then the final here is invest in women. And what I really want to take the opportunity here is to make sure that we really support and promote women in research, bench research, but also to bedside. And also when it comes to venture capital, really support women-led organizations. Because at the end of the day, who knows better about females and women disease than women? And I also think that we know that we're lacking a lot of women in leadership positions. So it's important not only to focus in on the diseases that actually affect women, but also support and fund research that's being led by women. And finally, I'm also going to give a comment around the financial impact. And this is, again, as I said, from the World Economic Forum of earlier this year, that if we boost data availability and provide the appropriate care to women and invest in treatments that actually affect women, this could create an almost 400 billion annual economic improvement by 2014, so in just 15 years. So again, there's also a huge opportunity here for biotech and pharma industry to hone in and focus in on women's health, also from a financial perspective. This is just a fun picture I'm showing. This is from JP Morgan, for those who doesn't know what that is. That's the largest pharmaceutical biotech investment conference taking place in San Francisco on an annual basis in January timeframe. That's where everybody meets, and that's where they share, that there has been mergers, acquisitions, important data, people are seeking funding. So there is a huge activity in January in San Francisco around this. This year, it was a great opportunity. Women, senior executive women that were participating here from around the world gathered at Union Square to showcase women's representation at this big event. They all dressed up in very bright pink colors, and it's called the Biotech CEO Sisterhood. But again, it's really to support and ignite investments into biotech and pharma, and specifically then focusing in on supporting female leaders. And so with that said, I hope to see everybody here that are not only women, but also support women in leadership positions at JP Morgan in 2026. And with that, I'm going to give the floor over to Emily. Thank you so much. And if you have any questions, the organizers have my contact information. So thank you.
Okay, so I think I'm taking over now. That was excellent. I really enjoyed it, Dr. Rosen. Hi guys, my name's Emily Sims. Let me share my PowerPoint. Okay, so I'm a researcher and a pediatric endocrinologist who studies type 1 diabetes. So I'm going to talk about women's health from a type 1 diabetes perspective today. And we already had a pretty nice introduction about this. But just to kind of review some of what we heard about already, type 1 diabetes is an autoimmune disease that leads to destruction of those beta cells in your pancreas, which are the cells that make insulin. And we're coming up now. We've just passed the 100th anniversary of the discovery that you can treat people with type 1 diabetes by giving them insulin back in the form of injections. And at the time that this was discovered, it was really heralded as a miracle cure. And when you think about people who were living with type 1 diabetes at the time, this was really the case, right? This is an image of one of Dr. Banting, the person who's credited with discovering insulin's first patients. Her name was Elizabeth Hughes. And you can see, this was something that was basically a death sentence for patients living with the disease and was transformed into a chronic medical diagnosis that could be treated with insulin. Oh, I do need to switch modes. Sorry, that's what I was wondering. Hold on, guys. Let me see if I can.
Now,
see the right one? Now
it's in presentation mode.
Okay, excellent. Thank you. Okay, sorry about that. Okay. Okay, so diabetes care really transformed for people with insulin, right? Starting in 1922 when we discovered that we could give insulin back. And then when you think about how diabetes care has changed since then, man, we've really come a long way, right? So, thinking about 1922 when Banting and Best were giving this islet extract to dogs who had had pancreatectomies, the way that we can care for our patients has really, really changed over time. Most recently with some really incredible technologies that allow us to monitor blood sugars less non-invasively and administer insulin using these pumps. And you can see an image of a woman who is wearing one of these insulin pumps on the side of the screen. And so she has a sensor that's non-invasively monitoring her glucose and then a pump that's administering insulin. So this is really amazing. It helps with quality of life a lot, I think. But I would argue that we really still have a lot of strides to make for our patients who are living with type 1 diabetes. We know that this disease still causes considerable morbidity and mortality, so long-term health impacts due to complications from having high blood sugars over time, but also from having low blood sugars, which can be a side effect of taking insulin and can be life-threatening and really, really scary for patients and their families. And then additionally, there's this metabolic derangement that comes from not having enough insulin in your body that's called diabetic ketoacidosis. And people frequently present with a new diagnosis of type 1 diabetes in this diabetic ketoacidosis. This can also be life-threatening. It's very expensive and can have some long-term complications. And then finally, even if everything is going perfect with your type 1 diabetes, this is a disease that's associated with considerable cost. It's really expensive to afford all of these insulins and technologies to take care of diabetes. And, again, even if everything is perfect, having type 1 diabetes, even with the new technologies, is basically like having another full-time job. You're always having to think about, what's that blood sugar looking like? What's the next thing you're going to put in your body? Thinking about your plan for the day, what kind of activity you're going to have. This image of the pumpkin on the side of the screen is the number of insulin injections a mom had to give her kid over a month. And it's just kind of really staggering to think about, what patients and their families are having to deal with on a day-to-day basis just to kind of manage their disease and do what their doctors are asking them to do. So what about women? Unfortunately, like many diseases, women are disproportionately impacted by type 1 diabetes, even though rates of type 1 diabetes overall are similar in women and men. And as we've heard already, In terms of mortality or long-term death related to diabetes, women really have excess risk related to men. This tends to be related to heart disease, coronary heart disease, stroke, and heart disease overall related to type 1 diabetes extra risk, as well as kidney disease. In addition to this, we know that hormones are really important for diabetes, and that hormones affect your blood sugar. And women have big changes in their hormones every month associated with their menstrual cycle that can really affect your blood sugar management and make things more complicated. Additionally, menopause is associated with big changes in hormones and can really have big changes on your blood sugar that can be complicated. Additionally, we know that women who have poorly controlled type 1 diabetes can really experience big impacts on their menstrual cycle, and on long-term fertility. And then finally, having a pregnancy in type 1 diabetes, which is the decision that affects many women, is very complicated. It requires a lot of advanced planning because you really want to have very tight blood sugar control before and during your pregnancy to avoid complications. We know that babies exposed to high blood sugars in utero can develop birth defects, especially in the very early parts of pregnancy when those organs are developing. And then if the baby's exposed to high blood sugars, they can also be bigger than expected, which can lead to complications with the actual delivery and birth. And then problems after having the baby, especially with blood sugars in the baby and for mom. Okay, so finally, I just wanted to point out that emotional stigma is something that is disproportionately affected in women living with type 1 diabetes who report increased feelings of guilt, shame, blame, embarrassment, and isolation. And this is actually also frequently associated with disordered eating, which is really common in women with this condition, more so than men. And, I think if you think about it, it makes sense, right? Because you're really just having to think about and really analyze every single thing that you put in your body. Taking insulin can cause extra weight gain, which can kind of put additional pressure on women who are already living with all of the pressures of society and thinking about your weight. So what I study is this idea that we need to be rethinking the way we treat and we diagnose this disease. The kind of classic thinking about type 1 diabetes is that you inherit a genetic risk or predisposition to the disease, and then you encounter some sort of environmental trigger that activates that autoimmunity and destroys those cells that make insulin. And then over time, you lose more and more of those cells until almost all of those cells are gone, and you present with those classic symptoms of diabetes, and then we give you the insulin back. But we know that this process actually develops over years and can be detected well before you've lost that kind of critical amount of beta cells. And so, kind of as we heard from Dr. Rosén, wouldn't it be great if we could use treatments that target the underlying pathophysiology of the disease so that we can prevent a person from losing all of those beta cells and they can make more of their own insulin, maybe even not need insulin long term or delay the need for insulin. And this has been a really exciting time in this field because a couple of years ago, there was a prevention trial. And then in some countries, there's been regulatory approval, including the United States, for a drug that targets T cells that's able to delay the onset of type 1 diabetes. In the hospital I work in, we've started giving this to patients, which has felt really exciting and felt like we're moving the needle. But I think most of us who are in this field, realize that this existing drug is just the beginning. It has a lot of pros and cons. And when you think about this kind of very complicated pathophysiology in lots of different ways and mechanisms that type 1 diabetes develops, there have been a lot of really good potential agents that I think could potentially do even better or be used as part of combination regimens so that we can get a really durable, long-term preservation of those insulin-producing cells and delay in the need for insulin in patients who we know are going to develop diabetes. And so, taking this back to women's health, what are the opportunities here? I think because women are so disproportionately affected in terms of quality of life, really just disease modification, improved type 1 diabetes, and everybody is going to have big effects for women who are affected by this disease. But, as we've already heard, I think it's also going to be really critical moving forward, as we study these different kinds of treatments and disease preventions to really understand differences in the sexes, both so we have a better understanding of differences that give us insights into pathophysiology of the disease so that we can identify new therapies potentially that can target the disease, but also so that we can provide more precision approaches to each individual's diabetes care and give them a better regimen that will hopefully be more effective. And that is the end of my talk. So I will stop sharing.
All right. So like Emily mentioned, I remember, and looking back now, I understand it even better. But when I was diagnosed at age 13, I was a very normal, lean weight for a 13-year-old. And over the course of high school, I gained probably 25 pounds and no one ever talked about it. And now I can look back and see, like, oh, it wasn't my fault. Like, I wasn't eating more than my peers, and I didn't understand why I couldn't be the same shape they were. And I felt overweight and I felt kind of puffy. And I managed my diabetes really carefully for a teenager, especially this is 1999. But it was like it didn't matter what I did. I just kept gaining weight. And that weight gain, I think, stopped around 25, 30 pounds, but I was active. I ate real food. I ate healthy food. It didn't make sense. And now I can look back and see that the combination of type 1 diabetes with the major hormones that adolescent girls go through, that the estrogen and your entire menstrual cycle, the insulin resistance that that creates is so significant when you're now taking injections of a synthetic hormone. And I now know today that on top of that, there's other hormones that people with type 1 diabetes don't regulate normal amounts of that absolutely affect insulin sensitivity and weight. And so it means it's extra hard for anyone with type 1, regardless of their gender, to manage their weight and their appetite, which is why GLP-1 medications today have been so helpful for people with type 1 who've been able to get their hands on them. And that's a whole different topic. We could spend hours just on that. But I had to learn in my 20s basically to ignore my body's hunger cues. I didn't understand it at the time that my body doesn't naturally regulate the hormones and the signals that go to the brain to say, hey, you're full, or hey, you're not hungry anymore. Hey, you don't need any more food. But I did understand that for some reason, my body wanted more food, even though I already ate a normal amount of food. And I had to learn to ignore it and feel hungry throughout most of the day in order to eat a normal amount of calories and maintain my weight at the weight I wanted to be and that I felt healthiest at. And that was exhausting. I'll tell you, that is exhausting. And now that GLP-1s have made weight and weight loss such a big topic of conversation, I hear from so many type 1s who are so frustrated with their weight, especially women. And it continues, as we hit into perimenopause and menopause. Weight gain is already hard enough for women without type 1 diabetes. Now add type 1 diabetes to that, and it's just this extra burden of trying to budge that scale and trying to feel your best self. Weight is just a number, but it does influence how you feel about your health and yourself. So it matters. And then the actual blood sugar management around those hormones is so underappreciated and under discussed. There's that 28-day cycle, but for a young woman or an adult with type 1 diabetes, we're all a little different. And we're all trying to figure out, okay, does my insulin sensitivity shift a little bit on the day I ovulate? And then a few days before my period starts, does it start to change for me the hour my period starts? Whereas I have friends who will say that, the 3 days before their period starts, things change for them. And if you're not familiar with type 1 diabetes, when I say things change, I mean that their foundational insulin doses, their basal insulin dose significantly changes. And we're trying to chase like this moving target of our hormones throughout a 28-day cycle versus in a male body, those hormone levels are relatively stable all the time. In the female body, all of these hormones affect insulin sensitivity. And yet, many women will tell you that they've gone to their gynecologist or their diabetes team and said, my blood sugar does such crazy things during my period. I don't understand what to do. And it's so hard to keep my blood sugar in my target range during that week. can you help me? And I can't tell you how many women have said to me that when they expressed this to their healthcare team, they were told, no, that doesn't affect your blood sugar. Your period doesn't affect your blood sugar. It's no big deal. And I mean, we have science that documents that it does. So it should never, no woman should be left to feel like she's crazy in this. But I can tell you that the way my period affected my blood sugar in my 20s is different now that I've got one foot in the grave. I'm 40, almost 40 years old, right? I'm joking. Please bear with me. But I'm approaching perimenopause, and I am seeing a change in how my menstrual cycle affects my insulin needs. And I actually now need a little micro dose of long-acting insulin at 2:30 in the afternoon to help me stay in range in the evening. Because for whatever reason, and I've heard from a couple other women in perimenopause who have expressed the same thing, my long-acting insulin dose just isn't lasting through the evening anymore. So it's these little tiny things that we have to deal with that are so precarious and specific. And while there's a general picture around hormones and how they impact you, from person to person is very different. Pregnancy. Emily touched on this, and I can't even begin to tell you how intense pregnancy with type 1 diabetes truly is, because it's not just you want healthy blood sugars before getting pregnant. It is an hour by hour pressure. You feel like you're a bad mother before you've even met your child because you see a blood sugar over 160. It's this constant pressure, and again, constantly shifting insulin doses. So every week, and sometimes if you're lucky, you might go a couple weeks, but you're making adjustments to your insulin doses, trying to stay in nearly non-diabetic target range, which is not something I'd really strive for outside of pregnancy. It's exhausting, and it is truly a full-time job, plus maybe a part-time job if type 1 is already kind of a part-time job. It's so much, and you feel so much pressure for the sake of your unborn child to do perfection in a body that isn't regulating actually 6 hormones properly, right? Insulin is just the one that we don't produce, but there's 5 other hormones that should be regulated properly that are not being because of the attack of those beta cells. So pregnancy, it is by far, I feel, really the hardest thing a woman with type 1 could decide to do. And I'll tell you that I used to think in my 20s, my early 20s, and teens, that a woman with type 1 should not pursue pregnancy. I was adamant about this as a teenager. I thought it was selfish. And it was because I was terrified. I was just really scared of that idea. And then I started seeing women with type 1 online sharing their pregnancy journeys. And I realized, like, oh, if they can do this, I can do this, and I can pursue pregnancy. It's one of the scariest decisions a woman with type 1 will make. I will leave you at that. Here are some places to find me, and I am a co-author of a book, Pregnancy with Type 1 Diabetes. We just published a second edition on Amazon.